Hello, welcome to my channel. So today we are going to go through sickle cell disease. So in terms of definition, it can be defined as a genetic disorder in which there is inheritance of two abnormal genes coding for hemoglobin, and one of which codes for hemoglobin S, or you can also define it as a hemoglobinopathy, which is characterized by inheritance of two abnormal genes coding for the formation of hemoglobin, one of which is the hemoglobin S, which is the sickle hemoglobin. Okay, then in terms of genotypes, we have the HBSS, HBSC, HB beta thalassemia, and HBSD and HBSO. Okay. Then in terms of types of hemoglobin, so we have the adult hemoglobin, which is denoted by the letter A, HbA, and which is composed of two alpha and two beta chains. Then we have fetal hemoglobin, which is denoted by the letter F, and it is composed of two alpha and two gamma chains. And other abnormal HB include C, HBC, HBD, and of course others as well. Okay. Then we have the sickle cell hemoglobin, which is the HBS, which results from a single base mutation of adenine to thymine, which produces a substitution of valine for glutamic acid at the sixth codon of the beta globin chain. Okay. Then in terms of forms of sickle cell diseases, so for the forms, we can have sickle cell anemia, where there is inheritance of two abnormal genes, both of which code for HBS. So it's homozygous for hemoglobin S, and usually there is a genotype HBSS, and it is symptomatic. That's the sickle cell anemia. Then sickle cell trait, there is inheritance of one abnormal gene coding for hemoglobin S, so it's hemizygous for hemoglobin S, and the genotype is heterozygous HBAS, and the other gene is normal, and the patient is thus asymptomatic. Then we have the sickle cell syndromes, where there is combined heterozygosity. So genotypes, for example, we have HBSC, so where the HBS and the HBC have combined together. Then there is usually intermediately symptomatic, that is associated with the presence of HBS and HBC, or HBS and HBD. Okay. Then in terms of epidemiology, you find that the sickle cell trait has actually been estimated at 18% in the Zambian population in 2017. Then the sickle cell disease patients accounted for 12% of the total all-cause admissions at the UTH General Hospital in 2017, and yet sickle cell disease was the fourth of the top 5 causes of mortality among the children admitted to UTH Children's Hospital in 2017, and top 10 among the causes of seeking medical attention. Then also in a small cross-sectional study in Tambo area in central province of Zambia, in 2017, during an outreach program, 503 children aged 3 months to 18 years were screened for sickle cell disease. Of the screened individuals, analysis of the dried blood samples revealed that 78 had sickle cell trait and 17 had sickle cell disease, and the prevalence of 15.5 and 3.4% respectively. Okay, so in addition to this, in addition to them being sickle cell disease and having sickle cell trait, there is also a case of lead poisoning in central province. So there is a lot of cross-sectional studies which are being done. Okay. Then in terms of etiology, so this is an autosomal recessive disorder or disease that results from a substitution of glutamic acid, which is hydrophilic, for valine, which is hydrophobic, at position 6 of the beta globin chain, and which results in the new HB. So the new resulting HB is HBS, Okay, that's the resulting HBS. So all this what you are seeing, A2 and B2, 6 groups, that's just alpha, 2 alpha chains, 2 beta chains on the 6th codon, where the glutamic acid is substituted for valine, which that's what results into the HBS. Okay, then this disorder results from a point mutation where the GAG changing to GTG on chromosome 11, position short arm on position 15.5. That's where the point mutation is. Then in terms of pathophysiology, is that when that same results in HB as the same resulting HB as the physical properties of forming polymers under deoxygenated conditions, and it is also insoluble polymer formation at concentrations exceeding 30 grams per deciliter. Then polymers form a gel-like substance containing HB crystals called tackoids. Then the resulting HBS can't withstand hypoxia, hence if exposed to low oxygen tension, the abnormal beta chain contracts and piles together within the red blood cells. And when this happens, the HB polymerizes. So the polymer is just a loop-like fiber that align with others to form a bundle, distorting the red blood cell into characteristic sickled forms. Okay, then the RBC distortion leads to intravascular sickling with subsequent there are two things which we are going to result. One of which is aggregation, then the other is hemolysis. So in terms of aggregation, these same deformed RBCs shaped, the deformed sickled shaped cells, since they have become rigid, clamped together, and formed masses of RBCs, they can occlude the microvascular secretion, producing vascular damage, organ infarcts, painful episodes, and other symptoms associated with SCD, which leads to vascular occlusion. Then in terms of the subsequent point, which is hemolysis, so the deformed RBCs have a shortened lifespan and rapidly trapped and demobilized in reticular endothelial system, specifically in the spleen and liver. So in conclusion, these are just the two cardinal pathologies, which are pathological processes, which is hemolysis and vaso-occlusion. Okay, so in terms of the sickled RBC lifespan, which is greatly reduced about 10 to 20 days instead of the usual 120 days. Okay, and from here you can spot the difference, where in this picture here you have normal red blood cells, but in this picture there is one sickle cell, which is one sickle red blood cell, which is here. Then we have multiple ones, so here and here as well as this one. Okay, those are the things you have to consider. Okay, then in terms of clinical features, you can have attacks of abdominal pain due to tissue ischemia, can have bone pain due to ischemia, breathlessness, where there is a cardiopulmonary involvement. Then there is delayed growth and puberty because of the energy demands of the bone marrow for red blood cell production competes for the demands of a growing body. So that's the point you have to take note of. Then fatigue due to tissue hypoxia and fever due to inflammatory reaction caused by tissue infection. And you have to know that how the inflammatory reaction, there will be release of interleukin 1, interleukin 6, and TNF alpha. So those ones are the ones which will be responsible for causing the fevers. Okay, by stimulating the hypothalamus. Okay, then that's for interleukin 1 and interleukin 6 and the TNF alpha. Okay, then in terms of The other symptoms, you can have a blood urine, which is hematuria due to renal damage following repeated tissue infection. Then you can have chest pain due to pulmonary infection or cardiopulmonary ischemia. You can have restlessness, especially during crisis, due to pain. You can have a painful erection, which is priapism, which occurs in 10 to 40% of men with the disease, and due to blood being trapped by occluded blood vessels. Then poor eyesight or blindness due to impaired blood supply to the retina. You can have cyanosis due to hypoxia. Then in terms of types of crisis, we can have sometimes the clinical features of the ACD are going to be termed as crisis. But when you ask to mention the clinical features, it's better you just go with the clinical features. But we then ask you the major types of crisis. We have one, the vaso-occlusive crisis. We have the hemolytic crisis. We have the aplastic crisis. We also have the splenic sequestration crisis, or you can just call it the sequestration crisis. Okay, so predisposing factors to a crisis, we have dehydration, infection, fever, strenuous exercises, severe trauma, exposure to cold, and change of altitude from low to high with low oxygen concentration. Okay, then specifically when we begin talking about the vaso-occlusive crisis, it is the most clinical manifestation of sickle cell disease. It occurs when the microcirculation is obstructed by sickle RBCs, causing ischemic injury to the organ supplied and resulting in severe pain. Then pain crises constitute the most distinguishing clinical features of sickle cell disease. Then they are the leading cause of emergency department visits and hospitalization for affected patients. Then predisposing causes of VOC, which is vaso-occlusive crisis, include cold weather due to vasospasms, hypoxia, infection, dehydration, especially from exertion or during warm weather. Then we have acidosis, alcohol intoxication, emotional stress, as well as pregnancy can predispose someone. Then this is just how the vaso-occlusion works. As you can see, here we have abnormal sickled red blood cells clamped together, thus blocking blood flow. Okay, because this is how the normal ones usually pass. Okay, then the pain can affect any body part, and it often involves abdomen, bone joints, brain, and soft tissues. Okay, then other types of VOC. So other types of VOC or examples of VOC, we have one which is known as the hand-foot syndrome, which is the dactylitis, where we have a painful and swollen hands and or feet in children due to bone marrow infection, as their small bones of the hands and feet undergo hemopoiesis. So this is due to bone marrow infection. Then the most common presentation in children aged 6 to it is the most common presentation in children aged 6 to 3 months of age, but it is rare after 5 years. So adults use long bone for this process, so that's why it's very rare. Okay, then the next type of VOC we can have is the cerebrovascular accident, which is a stroke, which is an acute neurological symptom other than mild headache, even if transient, requires agent evaluation. Okay, so a stroke is also another type of vaso-occlusion crisis. Then we also have another one which is known as the acute chest syndrome. So the acute chest syndrome is a medical emergency which must be treated immediately in children, and in children it consists of there is chest pains, fever, cough, and tachypnea. If you do a FBC, you'll be leukocytosis, and also there will be pulmonary infiltrates in the upper lobes from the chest X-ray. Also in children, it is very difficult to distinguish acute chest syndrome from pneumonia, and it is usually caused by infection. Though the treatment involves treating for pneumonia. Okay. Adults are usually febrile and dyspneic with severe chest pain and multilobar multilobar and lower lobe disease. Then patients are otherwise at risk for developing acute respiratory distress syndrome. Then the acute chest syndrome can eventually lead to pulmonary hypertension and or copulmonary as well. So it can lead to pulmonary hypertension, and eventually it will lead to copulmonary, which is the right-sided heart failure, secondary to prolonged pulmonary hypertension from the pulmonary disease. Okay. Then the other thing which we have to concentrate on is the autosplenectomy. So autosplenectomy is actually due to repeated episodes causing infection in the spleen, which predisposes to life-threatening, overwhelming post-splenectomy infection. So overwhelming post-splenectomy infection due to encapsulated bacteria, which includes one, which is the Streptococcus pneumoniae, Haemophilus influenza type B, Salmonella species, and Neisseria meningitidis. So Streptococcus pneumoniae, Haemophilus influenza type B, then Haemophilus influenza type B, Neisseria meningitidis, then we have the Salmonella typhi, so shans. Okay. Then other types of VOC, we can have priapism, which is defined as a sustained unwanted painful erection unrelated to sexual stimulation and unrelieved by ejaculation. So priapism is a common complication. About 80% of boys and men with sickle cell anemia will have experienced at least one episode of priapism by the age of 20 years. Then in terms of classification, priapism can be classified as prolonged and stuttering. Where prolonged is where someone has a penile erection that is lasting for more than 4 hours, and this is actually an emergency condition. Then stuttering priapism, this is where someone has repeated penile erections lasting more than a few minutes but less than 4 hours. So stuttering priapism will usually resolve spontaneously, but may reoccur and may develop into prolonged events. So that's how priapism is. Then in terms of evaluation of a patient with priapism, you can document the onset of erection, document possible inducing factors, ask for any history of trauma, infection, if the patient has a full bladder, prolonged sexual activities, you can ask. Then drugs, alcohol, psychotropic agents, and also use of sildenafil, and also for testosterone as well. And on examination, we're going to find the hard penis with a soft glans. Okay. So then in terms of complications of priapism, so for gender sickle cell disease care and counseling of patients on effects of priapism, that is, there can be impotence, and possibility of recurrence should be mentioned to the patients after recovering from the complications. So the complications already, we mentioned impotence already. So the other complication is fibrosis, which usually arise from frequent and recurrent episodes of priapism. Then other types of VOC, we can have acute joint necrosis or avascular necrosis. So the most common avascular necrosis is avascular necrosis of the head of femur. Okay, then we can have acute abdomen, which is due to intestinal ischemia or necrosis, or we can also have cholecystitis as well. Then we can have papillary necrosis causing chronic renal failure and leg ulcers. Then in terms of hemolytic crisis, so in sickle cell disease patients, the common cause in Zambia is malaria. So of course you have to do RDT and MPS. And the HB is you have to know that the HB is very fragile and easily hemolyzed, where severe hemolysis may lead to low oxygen carrying capacity, which will lead to oxygen tension, which will lead to low oxygen tension, thereby precipitating a crisis. Then in terms of the other features of hemolytic crisis, we have to know that the reticulocyte count is high in hemolytic crisis, and for SCD patients, the HB is usually, you have to know that for HB patients, the HB is usually 6 to 8 gram per deciliter, and it is lower than normal in short. So you have to worry when HB is less than or equal to 5 gram per deciliter. So other things you have to notice will be jaundice, gallstones. Then in terms of hemolytic crisis, someone may develop cardiomegaly, which may lead to congestive heart failure. There will also be marrow hyperplasia. So bone marrow hyperplasia may lead to frontal bossing. Then there also may be poor physical development and delayed maturation, since we said the demand for growth and demand for production of red blood cells compete. They compete for energy. Okay, that's why we may end up having poor physical development. Okay, then in terms of aplastic crisis, it is caused by infection with the parvovirus B19. So the parvovirus B19 divides in red blood cell precursors and destroys them. So meaning the erythrocytes. So it stops erythropoiesis for 2 or 3 days, and it ends up causing reticulocytopenia, and it disappears within 1 week with management and blood transfusion. So this virus causes what is known as the fifth disease, or erythema infectiosum, which is where a normally benign childhood, disorder associated with fever, malaise, and a mild erythema rash on the cheeks. But if it occurs in a sickle cell disease patient, that will be a bad combination. So this virus infects red blood cell progenitors in bone marrow, resulting in impaired cell division for a few days, like we mentioned. And in healthy people, they experience a slight drop in hematocrit. But in sickle cell disease patient, a shortened in a sickle cell disease patient with a shortened RBC lifespan, patients usually experience a very rapid drop in the red blood cells and then the hemoglobin. Okay, then the bone marrow usually recovers in 7 to 10 days. Then, unlike in hemolytic crisis, the reticulocyte count is actually low. Okay, that's one of the distinguishing factors. Then, in terms of the splenic sequestration crisis, it is an emergency, and this is because the spleen pulls large volume of blood, and patients can go into hypovolemic shock and death as if there is a severe hemorrhage. Occurs with highest frequency during the first 5 years of life in children with sickle cell anemia, and is characterized by the onset of life-threatening anemia with splenomegaly and high reticulocyte count. Then parents should be taught the signs and symptoms of splenic sequestration crisis, and splenectomy should be done in older children more than 2 years. Then the spleen is still needed for its immune function in young children. That's why the latter we said splenectomy should be done in children older than 2 years. Okay. Then in terms of complications for sickle cell disease, we can have acute and chronic. So the acute are the ones mostly we are talking about. So the crises and the bone pains, okay, the priapism. But in terms of the long term, so main organs can be damaged, so you may end up having strokes, heart failure, lung, pulmonary hypertension plus copulmonary, chronic kidney disease, liver and biliary chronic liver diseases. You can have osteomyelitis, frontal or parietal bossing due to compensatory extramedullary erythropoiesis. Okay, we can have blindness due to sickle cell retinopathy, and also growth failure. Those are some of the long-term complications. Then in terms of diagnostic investigations, We can have it can be done in utero, where we have restriction, endonuclease analysis of fetal fibroblast DNA, which is a PCR, via amniocentesis or chorionic villi sampling. Then we can have extrauterine, where we have laboratory, and under laboratory, we can have a sickling test, HB solubility testing, HB electrophoresis, and genetic testing by PCR, which is rarely done. Then imaging, we can do skull X-ray so that we see what they call air on end appearance. So that's what the characteristics feature you may see. So air on end appearance. Okay. Then the test to demonstrate sickling of RBCs. So the sickling test shows sickling of the red blood cells on a blood film upon addition of sodium metabosulfate. And in terms of HB solubility testing, if HB is mixed with reducing solution such as sodium diethionate, the solution becomes turbid in appearance. And then in terms of the normal HB, which is HBA, it gives a clear solid. It gives a clear solution. But for the one which is HBS, it will give a turbid solution. So you have to note that these do not distinguish between sickle cell disease and sickle cell trait, and we will not therefore even tell if patient has sickle cell anemia. Then in terms of the HB electrophoresis, it is the form of gel electrophoresis on which the various types of hemoglobin move at varying speed. So diagnosis can be confirmed with HPLC, which is known as high performance liquid chromatography. Okay, that's where the diagnosis can be confirmed. So this test diagnoses the type of SCD. For example, you can know whether someone has sickle cell anemia or what type of sickle cell disease they actually have. Is it trait or whatnot? Then in terms of imaging, we talked of the skull X-ray. So the skull X-ray in children shows the characteristics, air on end appearance of the bone trabeculations. So this is as a result of expansion of the bone marrow into the cortical bone. And then the other test, which is genetic testing, which is the PCR, which is there done. Then the other diagnostic investigation for crises. So laboratory, we talked of the full blood count, where the normal, we said you have to remember that the normal is for an SCD patient should be 6 to 8 gram per deciliter, and the reticular count should be slightly elevated, do continuous hemolysis. Then in terms of the peripheral blood smears, we are going to demonstrate target cells, elongated cells, and the characteristic sickle erythrocytes. Then there will be presence of RBCs containing nuclear remnants. So these ones, we call them oil jolly bodies, which indicates that the patient is asplenic. Okay. Then you can also do malaria, DT, MPS. Okay. Then in terms of imaging, depends on the presentation, but you can also have a laboratory where you can do the screening in a case of sepsis. So you can do your BAS, which is the blood, urine, and stool for MCS, urinalysis, and also lumbar puncture if indicated. Then under imaging, you can do radiography such as in chest X-ray, for example in acute chest syndrome or sepsis, abdominal X-ray, ultrasound, echocardiograph, for example in CCF or CT or MRI in terms of brain in strokes, or you can also do the transcranial, the Doppler transcranial ultrasound. So Doppler transcranial ultrasound, DTC, Doppler transcranial ultrasound. So that's the one we can do in a CVA patient, in sickle cell disease to be specific. Then supportive investigations, we can have UNDs, particulate 9, RFTs, ABGs, and ECG. And then in terms of treatment is dependent on the type of crisis. So of course you have to do your ABCs, a primary survey, and you treat the crisis appropriately. Then in case of complications, consult the experts. Then patients, education, genetic counseling, and routine regular follow-up after discharge. So genetic counseling should be comprehensive, making sure that the patient or guardian understand the condition. So of course the other thing you can do, talk about the immunization, daily folate for life, malaria prophylaxis, which is the Delta Prim. Okay, and of course this is not the only one. We have also other malaria prophylaxis, penicillin prophylaxis, and also have to educate them on precipitating factors, educate them on spring sequestration crisis, and also counsel on nutrition, where of course the child needs to grow as well, so nutrition is a very important support. Then in terms of medication used in sickle cell, we have antimetabolites such as hydroxyurea or hydroxycarbamide, which reactivates the fetal hemoglobin production and decreases the severity of attacks, increases the lifespan, and it affects the DNA, resulting in increased production of the HbF, which inhibits sickling. Okay, that's the thing about hydroxyurea. So it reactivates the fetal hemoglobin production. Okay, or hydroxycarbamide. So in terms of indication, it is indicated for children more than 5 years of age who have severe complication of sickle cell disease. And by severe complication of sickle cell disease, you can say, okay, someone has more than 3 crises in a period of 6 months. That's a severe complication of sickle cell disease now. And it's effective because it increases. It's effective because it increases the fetal hemoglobin, decreases leukocytes, platelets, and reticulocytes. Then the full blood count must be monitored regularly when on therapy for leukopenia. Okay. Then analgesics, opiates, NSAIDs. You have to know that you have to lower the dose of narcotic drugs. Then antibiotics, variety for confirmed infection. Then vitamins, of course, folate, which is vitamin B9 for life, which is necessary for erythropoiesis. Then supplemental folic acid replenishes depleted folate stores secondary to hemolysis. Then ion chelators such as dysferriosamine, B-mesylate, which is DFO, B-mesylate, can also be given, but this one there should be indication for you to give ion chelators. Then also known as deferoxamine or dysferoxamine B, which is indicated in which of course you have to know that iron overload is actually a consequence of the numerous blood transfusion which is required. So for iron overload or iron poisoning, the antidote is deferoxamine. So iron overload leads to hemochromatosis with complications such as CCF, liver failure, and bronze DM. Then iron chelators help maintain HB levels within the desired range. Then phosphodiesterase type 5 inhibitors. So for these other drugs you can use to treat pulmonary hypertension associated with sickle cell disease. Also used to treat priapism associated with sickle cell disease. Then you can have endothelial receptor antagonists such as bosentan, which is used for pulmonary hypertension associated with sickle cell disease. Okay. Then that was the pharmacological therapy. Then for the non-pharmacological therapy, you can have other approaches such as the stem cell transplantation, which can be curative. Then we can have transfusions for sudden severe anemia due to acute splenic sequestration, parvovirus B19, hyperhemolytic crisis, and also a CVA. Okay. wound debridement, physical therapy, heat and cold application, acupuncture and acupressure, transcutaneous electric nerve stimulation, which is known as TENS. Then in terms of combination, so we are now on combination of pharmacotherapy and non-pharmacotherapy. So of course, vigorous hydration plus analgesia for vaso-occlusive crisis. That's how you actually manage it. So vigorous hydration and analgesics. Then oxygen, supplementation, antibiotics, analgesics, incentive spirometry, simple transfusion, and bronchodilators for treatment of acute chest syndrome. Okay. Then in terms of vaso-occlusive crisis, the goals is that it is an hematological emergency, and quickly assess the severity of the pain. And goals of assessment are that you have to characterize the pain and the related experiences, assess the cause of pain and complications, assess pain intensity, provide basis for therapeutic decision, and document efficacy of pain control and rapid assessment of acute pain. Then the scales for pain, you can use the faces pain intensity scale or the visual analog scale. Okay, but usually sometimes if when you're assessing pain in practice, you find that sometimes it may be exaggerated by the patient, or you may actually reduce the severity of the patient using a visual analog scale. Okay, then you can also have a multidimensional scales. Okay, then emergency treatment of a VOC, of course we begin by hydration, and your bit, if you can also give blood transfusion in refractory crisis. Of course, you have to give at least 1.5 times the maintenance, or 2250 ml per square meters per day. Also add 5% dextrose. Analgesics, you have to follow the WHO pain ladder control. Of course, if there is severe pain, you might give morphine 0.15 milligram per kg per dose per oral or subcut every 3 hours. But if there is moderate pain, you can give oxycodone, which is about 5 to 10 milligram per dose, or methadone. But remember, this the management is not necessarily cast in stone, so you have to follow your hospital guidelines. So follow guidelines. So follow your hospital guidelines. Okay. So guidelines may differ per hospital and also with availability of pain. Then if there is mild pain, you can give ibuprofen, acetaminophen, which is about 1.5 milligram per square meters per day every 4 hours. Okay, then in terms of antibiotics, for encapsulated bacteria, IV natural penicillin such as benzyl penicillin or X-Pen at 50,000 international units per kg to cover for streptococcal pneumoniae and Neisseria meningitis. So remember your shans. Okay, your encapsulated bacteria. So chloramphenicol to cover for Salmonella and Haemophilus influenza type B. Then other broad spectrum antibiotics for other bacteria, you can give the third generation cephalosporin, cefotaxime, metronidazole for anaerobes. Then in terms of acute chest pain, acute chest syndrome, you of course you have to rehydrate the patient and beat in refractory crisis, nasal O2. So you can start at 2 liters per minute, then you escalate as circumstances arises. For hypoxic hypoxemic patients, then antibiotics for febrile and severely ill patients, you can give your IV penicillins, your X-Pen or chloramphenicol. Then other broad spectrum antibiotics such as cefotaxime, in adults ceftriaxone, okay, and then metronidazole for anaerobes. So macrolides such as erythromycin to cover for mycoplasma pneumoniae. So pain control, again you have to follow the WHO pain ladder control. Then in terms of management of priapism, if it's an at acute, if it's an at the onset of priapism, oral fluid and patient to be advised to attempt urination, oral analgesia, and also walking may be helpful, and home bath may also help avert early priapism by improving blood circulation. But if it's a penile erection lasting more than 4 hours, then of course we have to give intravenous hydration, or 2 liters per square meters per day, or 1.25 of the maintenance fluids. And if there is no cardiopulmonary compromise, that's how you can give. Then the pain control with opioid analgesics, and also you can give anxiolytics, and you also have to institute a simple packed red blood cell transfusion at 10 to 15 mils per kg. So your packed red blood cell transfusion, you can also institute it. Okay, then you also have to consult urology urology immediately for aspiration and irrigation. Okay, then if determinants, which is flaccidity, not achieved within 1 hour of admission at emergency room, then you have to institute. You are going to have to institute penile aspiration and corporal irrigation. So penile aspiration to be instituted within 4 to 6 hours from onset of priapism. So you have to prepare a 1 to 1,000 a 1 to 1 million solution of epinephrine in saline. You have to sedate patient and administer local anesthesia. Then you have to aspirate blood from the corpus cavernosum using a 23 gauge needle until flaccidity is achieved. Okay. Then you have to irrigate the corpora with epinephrine solution. Add 1 ml of 1% epinephrine to 39 ml of normal saline to make 0.25 milligram epinephrine, and inject 1 ml directly into the corpus cavernosum with a 27 gauge needle. Then injection can be repeated every 15 minutes up to a maximum of 6 injections. Then surgical shunts, if the above measures fail to relieve priapism, a shunting procedure will be necessary. So that's how you manage priapism. Then in terms of splenic sequestration crisis, early education to parents is vital, and if there is a it's life-threatening episode, so we have to use BT to raise the HB to 9 to 10 at least to 9 to 10 gram per deciliter, and also chronic BT program or splenectomy shortly after. Then chronic BT in less than 2 years to keep the HbS less than 30%, since you can't necessarily do splenectomy in less than 2 years. But once they just reached more than 2 years, you can do splenectomy. Okay, so that's how it works. Then in terms of fever and infection, laboratory evaluation, sepsis screening, including lumbar puncture if indicated. Then you can evaluate for stomatitis, administer to hospital if less than 5 years, and the temperature if it's more than 38 degrees. You have to cover for Staphylococcus pneumoniae and Haemophilus influenza type B. Then you have to discharge after 72 hours if you're febrile on oral antibiotics. Then review within 1 week of discharge, but again you have to follow your hospital guidelines. Okay. Then for a CVA, of course, immediate hydration with alkalinization and agent exchange transfusion or blood transfusion. Then after 1 to 4 weeks, you have to do a Doppler transcranial ultrasound or Doppler ultrasound angiogram or a brain CT or MRI scan. Okay, that's how you have to do it. Then if there is vessel obliteration, you have to give prophylactic transfusion. So you can even put the patient on hyper transfusion protocol. Okay, but if there are no vessel obliteration, then you just have to monitor. Then you have to know that acute red cell X transfusion is indicated in the following situations. If someone has acute infarctive stroke, you can give them blood. Severe acute chest syndrome, blood. Multi-organ failure syndromes, blood. Right upper quadrant syndrome. Priapism that does not resolve after adequate hydration and analgesia. Regular blood transfusion that are used for primary and secondary stroke prevention in children with sickle cell disease. Seed transfusion protocol plus hypertransfusion protocol. Okay, so these are some of the protocols I would like you to go through. Okay, then finally we have what we call the stem cell transplantation, specifically the allogeneic hematopoietic stem cell transplantation, which is HSCT, which can actually cure SCD. Then most transplants are performed in younger patients, and results are better in that population. Then to date, you have to know that the hematopoietic stem cell transplant has been considered indicated in sickle cell disease patients younger than 16 years of age with HBSS or HBS beta thalassemias who have severe disease as evidenced by one of the following. So if they have stroke or a central nervous system event lasting longer than 24 hours. If they have recurrent acute chest syndromes, recurrent severe crisis, more than 2 episodes per year for several years. Then recurrent priapism, impaired neurological function with evidence of cerebral infarction on imaging studies, sickle cell nephropathy, stage 1 or stage 2 sickle lung disease, bilateral proliferative retinopathy, and major visual impairment in at least one eye. Then osteonecrosis of multiple joints, and red cell alloimmunization with more than 2 antibodies during long-term transfusion therapy. So these are some of the indications for stem cell transplantation which can actually cure the SCD. Then complications for acute and chronic: acute pain, acute chest syndrome, priapism, acute splenic sequestration, chronic pain, cerebrovascular disease, pulmonary hypertension, leg ulcers, vascular necrosis of hips or jaw shoulders, retinopathy, renal failure. Then here we can even add copulmonary as well. And of course, there are also other complications. Then follow up. So follow up, we have to follow the hospital guidelines. Okay. So daily follow up of folic acid 5 milligram OD for life, and antimalarial prophylaxis such as weekly delta prim, such as dapsone and pyrimethamine. Then you have to advise on keeping warm, drinking lots of liquid, nutrition, and ensure health-seeking behavior. Then for pregnancy in sickle cell disease, so pregnancy actually represents a special area of concern. The high rate of fetal loss is due to spontaneous abortions. Placenta previa and abruption are common due to hypoxia and placental infection. Then at birth, the infant is often premature or has a low birth weight. Then this is the end of the tutorial. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And where you are not clear, feel free to ask questions in the comment section. And see you on the next tutorial as well. Okay, hit the bell notification and give us a comment and give us a like. Alright, see you on the next tutorial.